afternoon. I'm wishing to give you a heavy meal after lunch. I'm speaking today about hidden meniscal lesions. I don't like the name of hidden lesions because the eyes don't see what mind doesn't know. So there is nothing called hidden lesion, it's just something you don't know and you don't search for. By hidden lesion, I'm speaking about two lesions, the ramp lesion and the root tear of the medial meniscus. The ramp lesion, or called meniscocapsular lesion or hidden lesion, but the famous name for it is ramp lesion, is a rather common. This is the posteromedial attachment of the medial meniscus. When you look to the posteromedial attachment of the medial meniscus, you find the ramp lesion, and is the relation between the capsule and the medial meniscus. If you have a schematic drawing of the ramp lesion, you have the meniscocapsular ligaments, the meniscotibial ligaments, the posterior capsule, the adipose tissue. There is a laser pointer. That's one. Laser pointer. That's one. IT. That's one. Laser pointer. I will draw. This is the meniscocapsular ligament, and this is the meniscotibial ligament, and this is the arm of the semimembranosus muscle. The ramp lesions is first described in 1983, and it was not popular at this time. The incidence started from 8% and is now reaching 40% and is increasing because awareness of the lesion. People start to know this lesion more and more. It's difficult to diagnose with MRI. Should be anticipated and checked in all ACL cases. Easy to see in acute cases. In chronic cases could be missed due to healing in abnormal position. The biomechanical effect of ramp lesion, it affects the stability of the knee, both anteroposterior stability and rotational stability. This is the intact state. This study was done by Andrew Emes. This is the torn ACL. This is the torn ACL and the meniscal lesion. This is torn ACL with meniscal repair. This is ACL with meniscal repair, which is very close to the normal. And the last one is ACL without meniscal repair. The lesion shapes could be like an acute tear, could be in a chronic lesion. And this, I learned this ramp lesion from Mariani. He was doing this since 2006 on a routine basis. And he's calling this lesion a lapsa lesion of the knee. This is his video, the video of Per Paolo Mariani. I take this video from him. He's recognized this lesion and he starts repairing an ACL on routine basis since 2006, so maybe earlier than this. The treatment options is either repair or shaving. In partial lesions, we have to do shaving, and freshening. In complete lesions, we have to do repair. This is a patient, 21 years old, with acute ACL. If you examine the medial meniscus, you find a small tear in the undersurface of the medial meniscus. By probing, the meniscus is coming with you. So this is 21 years old with an acute ACL tear. When you go to the posteromedial compartment, I go through the posteromedial compartment and I open the posteromedial portal and I start to examine the posteromedial capsule. You find this lesion. It's exactly like the pancreatic lesion of the shoulder. It's displaced and sitting below. And if it heals in this position, it heals in abnormal position or in a lax position. So there is a complete drop of the meniscocapsular ligaments. In such lesions, I do repair, and I do repair in two steps. I take every part of the lesion in a single step to adjust the tension. So I have to take two bites. The first bite in the meniscocapsular, I take all the structures and I come with my hook beyond all the structures, and I pass through this Prolene a high tensile suture. On the other hand, I use a meniscal suture. It's a very nice trick in this position is to do internal rotation of the tibia. When you do internal rotation of the tibia, you have access to the posterior horn of the medial meniscus. And you pass your second suture. And of course, you have to do some suture management to pass these sutures. And after you pass the suture, you do the surgical knot or sliding knot, whatever you want. And this is the tension at the end before suturing. And this is the view through the posteromedial portal of the repair. You can take one suture, two sutures according to the lesion size. So we should look for every ramp lesion in every ACL, especially with high-grade pivot shift and male patients. In acute cases, it will be very obvious. In chronic cases, could be missed. The second thing I will speak about is root tear medial meniscus. And this is the posterior root of the medial meniscus. In this area, this is posterior root of the medial meniscus. And this is attachment of the posterior root medial meniscus very close to the PCL. It's not so much hidden. If you know the lesion, you'll find it easily. But if you don't know the lesion, you will miss it easily. But mechanism of injury of root is bimodal presentation. Could be in young age or in old age. Could be traumatic or with minor trauma. The most common scenario is acute on top of chronic, degenerative, little degenerative meniscus with mild trauma. Sudden onset of popping of the knee with or without trauma, abrupt decrease in the knee function, the patient has sudden drop in the knee function, may be followed by acute severe pain secondary to spontaneous osteonecrosis of the knee. Why it's important? Because meniscal, it leads to total loss of the meniscal function, and it leads to osteoarthritis within few years. So if you neglected the root tear, you will have osteoarthritis. And when you have a root tear, you have extrusion. Second, weight bearing on and forces on the knee, the meniscus is extruded outside the knee. This is the video showing with full extension how much the meniscus is extruded with flexion and extension. So when you see this video, with weight bearing, the meniscus is completely outside and there is high contact pressure between the femur and tibia. And also with examination, you can find, no problem. You can find an MRI spontaneous osteonecrosis of the knee, which is bone marrow edema, and it could lead to osteonecrosis and then insufficiency fracture and irreversible events. An MRI is very easy to diagnose root tear medial meniscus. The factors that had to be considered in root tear medial meniscus is age. Young age is favorable of repair. Old age is near toward degenerative process. But age is not a number, it's frequent according to every person. Alignment of the lower limb, quality of the cartilage, the weight of the patient body mass index, the time of presentation, is it acute or chronic, the meniscus quality, the amount of extrusion. So we have a biological factor and we have a mechanical factor. The treatment option is conserve, excision, repair, or high tibial osteotomy in cases of cartilage degeneration. My technique is started to do biological augmentation of the meniscus. This is a 45 years old female. I do pie crusting of the medial collateral ligament to open the space, and I do pie crusting to have a very wide space. And then I examine the lesion. I found the root tear. This is a subacute presented with after 1.5 months of the popping of the knee. Is not chronic, not acute. And then I prefer to do release of the meniscus because I want to have a tension-free repair. So I do circumferential extensive release. I check reducibility of the meniscus. When the meniscus is not freely reducible and there is tension, I do aggressive release of the meniscocapsular structures of the medial meniscus to have the meniscus resting in its place without any tension. After so, I pass my first suture and I put this suture a little bit medial than it should be because it will be for the biological fixation. With a curved hook, I pass the suture through the meniscus and I shuttle this suture. The second step, I do a transtibial tunnel in the footprint of the medial posterior root medial meniscus, not in the cartilage but in the bony part where the footprint of the cartilage is, and I take the shuttle suture through the transtibial tunnel. After which I pass a big suture in the first tunnel, is AC bond number 5 in double fashion. I use this AC bond to widen the meniscus, to make some hole inside the meniscus. So I use this AC bond suture as a rasp, and I do rasping a little bit of the meniscus. I do rasping of the meniscus with the suture, and then I pass two shuttle sutures in the tunnel. This type of surgery needs a little bit of putting the suture in order and some suture management. After that, I take another bite in the meniscus in the golden spot. The golden spot is the point where the meniscus is the strongest to pass the sutures for the fixation. So I take two bites in the meniscus. One is median and one is more central near in the golden spot. The first suture in the golden spot, I pass a suture tape. And I pass this suture tape through the transtibial tunnel. After I pass this tape in the transtibial tunnel, I use the AC bond to pass a gracilis tendon free graft through the meniscus. I pass the gracilis tendon free graft through the meniscus. So I have two types of fixation, one fiber tape and the other one is a biological gracilis tendon. And then I pass the gracilis tendon in the tunnel, and I do fixation under vision, under arthroscopic control. I reduce the meniscus and I do fixation of the gracilis tendon and the tape in the position. So root tear medial meniscus, the incidence of healing is around 80%. Proper selection of patient is mandatory. With improved techniques, we help to improve the results of the patient. Take home, if you know something, you can see it. Don't miss hidden lesion. Thank you.